All right, well then let's get started. So we will be recording the session, so everyone is aware. And I have the pleasure this morning of introducing Dr. Holly Martin and Dr. Angela Quiñones Hermosa. So Dr. Martin is an inventor of the breath device. It's the baby resuscitation enhanced ATEC helper. And this is an app and a sensor designed to improve and guide neonatal resuscitation in low resource settings. She's also an associate professor of pediatrics at University of California, San Francisco, and director of education for pediatrics at the San Francisco General Hospital, and a mentor that many of you have probably interacted with before through the Pediatric Leadership in Underserved, which is a request track. And Dr. Hermosa is a professor in the Faculty of Medicine at the Catholic University of St. Mary in Arequipa, Peru. For about 20 years, she's worked directly with the ministry. She has worked in the Ministry of Health, and her work focuses on primary care and multiple areas of research in the field. Her positions currently include medical director in clinics and international projects, and her passion is medicine and teaching young physicians in primary care, as well as a good couple of classes. With that, I will hand it off to you. And just to say to those joining, if you feel comfortable turning on your camera, we would appreciate it to increase interaction. And you can enter questions in the chat, raise your hand, or come off mute. The speakers do not mind interruptions. All right, to you, Dr. Martin.
Thank you so much. Everyone, please call me Holly. I am so excited to be here and taking advantage of Zoom so that we can welcome my longtime collaborator, Angela, to join me and really talk. I'm going to talk about Peru and my experiences there, but then really want to leave time for Angela to be talking about her experience really on the front lines during the pandemic, and then we'll come back together. I wanted to take advantage of sort of the complex nature to allow time at the end for us to all really have a conversation and think about how many ways our current position is going to be something that we reflect back on for the rest of our careers, how much of an effect this pandemic is having on the pediatric global health landscape, thankfully not in a direct COVID mortality way, but in ripples that I think will be extremely long lasting. So with that, I'm just going to jump in so that I actually leave the time that I want to leave for discussion. And Teresa, we're supposed to go till 12:30, right?
I believe so. Let me double check.
I think it was 11:30 to 12:30. I just want
12:30. Yep.
Okay, perfect. As some of you may know, I've been involved in global health really exclusively through working in Peru since I was in medical school. So first time I went down there was in 2005, which is now feeling like it's been a really long time. I've really stayed rooted mostly in Arequipa, which is the second largest city in Peru, in the south of Peru. My focus has been there because that's my husband's hometown. And before the pandemic, we were living down there for several years, and I would travel up to UCSF to do my clinical work and, have our family and our kids down there. And so it just really is a second home for me and has been the place where I've put all of my efforts for the past 16 years in terms of external academic work besides working clinically, where I work at the general pediatrics as a hospitalist. This is just a little bit of an outline of what we're going to try to cover over the next 55 minutes. I'll briefly skim over what used to be my whole hour of conversation with you guys, talking about the different projects that I've done in Arequipa. And then really we're going to kind of shift and really focus on the way the pandemic has affected Peru, and give Angela a time to talk about her experiences there, and then leave, I hope at least 10-15 minutes at the end for us to kind of have a group discussion about about all of it. So I, like I said, have been involved in Peru since 2005 when I first went down there right after my first year of medical school. I was inspired by this lecture I heard from Jeffrey Sachs, who's an amazing economist who really pulls together economics and global health. And he gave a really eye-opening lecture to me as a med student about diarrheal illness on the international stage, and how the tragic effects of that, which were very prevalent in Peru at that time. And that really became my focus in my first research project down there when I took a year off of medical school. And it's just evolved since then through the years as it continued to go down. My husband and I lived down there when I was in medical school, and then we were living down there the past several years before the pandemic hit. And then in 2020 in March, I was on a week-long trip up to do my regular week per month of clinical work at the General, and then got stuck because Peru shut the international borders, and my kids and my husband were in Peru, and I was trapped in the US. And it took us 3.5 months actually to get reunited, get my husband and kids to get the special State Department flight out of the country so that we could be together again. And we've ended up having to relocate back in the US because international travel continues to be such a beast to navigate. So we have relocated up here, and COVID has just given everyone a lesson on flexibility. And since then been, obviously in touch and working with Angela, but reevaluating the ways in which this sort of path of working on things and being able to be there every day is, for me, changed as someone who's in academics in the US and still working clinically, as well as with projects down there. So the projects that I was working on prior to the pandemic were a variety of different topics. The real uniting factor was that they were all related to pediatrics. So we worked on projects around anemia and anemia screening and treatment, worked on evaluating women's childbirth experience in the hospital and clinic settings, did adolescent surveys with teens in the area. Sorry, is that a question? No. Okay. And with the medical school, worked on creating simulation curriculum for them, and yeah, other things as well. Those are kind of the highlights. This is a picture of Arequipa from my apartment there, my house there. So it's a beautiful city and amazing collaborators in the city. And I had a lot of residents who would come down and work on all of these different projects with me. And I hope to have that again when things can be, borders can open up and stuff. But in the meantime, we're really dealing with COVID. But I want to change gears a little bit and just talk about the country of Peru, because I think that, as you all know, nothing can be taken sort of in isolation. And so much of the health and pediatric health landscape is influenced by the changes in Peru, and will continue to be influenced by the changes in Peru. And Peru has been an amazing success story in terms of economic development and advancement, decreases in poverty, decreases in child mortality over the past 20 to 30 years. And so you can see here how insanely the GDP increased and poverty decreased and life expectancy increased. And always remember that these life expectancy graphs are largely a reflection of child and neonatal mortality. So it's not that everyone's dying at 45, it's that huge numbers would die in the first year to 5 years of life, and then as that decreases, the average age of life increases. And even more recently, like looking at when comparing the first year I went down there in 2005, the poverty rate was over 50%. And it dropped precipitously over that period of time because of the increases in economic activity, all the way down to 2018, which is not reflected in the graph, but it went all the way down to 8.3%. Unfortunately, because of the difficulty in maintaining that economic rise during COVID, the estimates as of earlier this summer were that 3 million people had been put back into poverty because of COVID. And to put that in context, the population is about 33 million. So it's a large percentage. This graph is a little bit old, but I think it still is very helpful for thinking about like, okay, these economic changes were made, but what does that mean about the structure of the society? Where did things go? And so you can see that this economic stability, and this is comparing Peru to places where mining was a major factor, which is the industry, I would say, that's probably number one in terms of having the greatest effect in the economic successes in Peru. So comparing that to Latin American countries, similar mining countries, and aspirational peers. So the income of people in the country lagged. Economic stability they were a leader among that, but then employment, economic equality, and the environment all lagged. But really where you see the biggest issues are within health, education, infrastructure, civil society, and governance. And to me, that is kind of like a roadmap for thinking about why a country where there's been so much progress is still able to see such a rapid fraying when COVID hit. Just thinking about the number of ICU beds per person, the way the educational system was able to absorb the difficulties with COVID and having to be remote, and the system of government. Which kind of brings me to the next point, which is that as of now, Peru has the highest per capita death rate from COVID in the world. And Angela and I were talking about this, and I think that this is somewhat of a misrepresentation, because I don't truly believe that when everything is analyzed like say 2 years from now, and we're looking at excess death rates in all different countries all over the world, developing countries, similar lower middle income countries, et cetera, that it will maintain this sort of status as an outlier. I think most likely it is amongst a lot of peers that we're seeing this. And Peru has actually been able to really capture their statistics in a much better real-time way and represent them accurately, as opposed to other countries where even death rates, so even if you're looking at excess mortality, a lot of death registries are highly inaccurate. The UN says that like maybe half of all countries might not even be able to represent half of their deaths in real time. So I think there's huge limitations even to evaluating excess mortality, much less what's attributed to COVID. But Peru captured their excess mortality, appropriately attributed it all to COVID, and is now this huge outlier in terms of world data. That being said, it has been a really tragic hit on the country, with deaths that include deaths that we would hope could be avoided from lack of oxygen supplies and lack of ICU beds, et cetera. And I'm not going to get into that too much because I know Angela is going to kind of touch on some of that. But it's a situation in which it's almost 6,000 people per million in Peru, which is drastically different than the United States, for example, where we've been hit really hard, but we're at about 2,000 people per million. That being said, I feel like Peru has done a lot with the resources they have, given the situation that they started with. And so in some ways, I think there's a lot that isn't represented when you just look at the numbers, when you think about having extremely limited resources and being hit really hard from the very beginning, that there's a lot that they should really take as like amazing success in terms of preventing other deaths. Angela, are you still on? I can't see everybody on the thing. Yeah. So I'm going to turn it over to Angela, who has been my collaborator on projects for years and years now, and a very dear friend of mine, to talk about in more detail what's been going on in Peru, and give some background on the health system down there. Turn it over to you, Angela.
Hello, Holly. Hello, everybody. In this lecture, it's for me an honor to be with you, and thank you, Holly, and thank you for the nation. The health system in Peru, it's the way I see in short words, it's the 3 levels. I work in the first level, that it's consultory, and we see pregnant women for delivery, but only without the risk factors. The second level are the hospitals, and this third level, as the next diapo, we're going to see the third level is the institute that are more focused in some pathologies and that has a lot of activities in research. So this is how we are organized in Peru, our health system. Unfortunately, during the pandemic, it was too much for our system. It was so much that we have a very high mortality in our population. This is the way how we are organizing, what I said before. And the problem is that we didn't have this organization before. Now we in the medical center, we see every patient with insurance or without insurance. It doesn't matter now. And they enter by these health centers, and then we can send the patients to the hospitals if they need to be hospitalized, or if they have to go to the temporal center of isolation, because usually here the families live many people together in the same houses and sometimes in the same rooms. So we have to open these isolation centers so the patients could go there, get assistance, medical assistance, and stay there for 2 or 3 weeks, and they can go back home. Now we have this more organized, but at the beginning we didn't have it. So it was really a bad situation. With this model, we also started the organization in every medical center with 2 areas, the COVID and no COVID areas. Even the hospital has these 2 areas, but we know that the no COVID area, there could be patients with COVID. We know it, but we try to separate to decrease the viral charge, at least with the patients with COVID and no COVID. So we're going to see now that in many medical centers, we have to use these tents sometimes in the parking places, sometimes in some schools. So we could see there the COVID patients with ventilated areas because, as you understand, the health workers were afraid to get contagious. Many people died, and we're going to see it at the next in the next presentation. But this is the way how it was looked before we see patients, and this is how it looks when the patients arrived. And this is a picture of the hospitals because the emergency area was so crowded. It were too many patients, and they have to put these tents in the parking area, but still it was not enough. We have a problem with the oxygen therapy. We didn't have enough, so many patients had to take their own balloons with oxygen and wait for a space in a bed in the hospitals. Here we have 4 important hospitals. 2 of them became COVID hospitals, and the other 2 only focusing no COVID patients. This is one of the COVID hospitals, the general hospitals. So this is the first that collapsed during the pandemic. In the next presentation, we're going to see some more, in the next diapositive, we'll see inside the area. Now it's more organized. If you see this picture, it's not so crowded. It's the way how it is when we were after the waves. I mean, when we have a decrease of cases, so it's better. They have to build many areas in 1 or 2 months. Even if they did it, it wasn't enough. This is an example of the triage area in the general hospital. When the patients enter, it was so crowded that they had to wait even in the parking places. But because of this, we had a very high number of deaths.
Angela, sorry to interrupt you. When would you say was the worst time, like the worst months? Opinion.
Here in Peru, we started the quarantine since March last year, and the top of the first wave, it was July and August. And during July and August, we have the worst situation because we were not prepared. Now we're better prepared than before, but in that time, even many doctors died, even relatives of close people died, entire families were affected. It was too much. Even we have now the consequences, and also psychological problems with the patients and with the health workers. Now we are afraid because the actual situation, the current situation, is that the variants are increasing again the number of patients and the number of deaths because people is receiving the vaccines, but we're still identifying these new variants, and we are thinking that we are going to have again a third wave that's going to be high as last year. Okay, in the next presentation, in the next one, I think it's going to be easier to show that the Lambda variant is the higher now in our country, in all the regions. After that, we have the Gamma, but we are seeing that all the other variants are increasing. So we have only one place that can check, that can process the samples, and it's in Lima, in the capital city of the country. And they process, this is until August, 3,804 samples, and this is the result. So in every city of the country, we don't have this kind of lab. So we have to send all the samples to Lima, and they can show the results. But
I think this is a representation because this was over a long period of time, right? That all these samples.
Yeah, it is.
Delta
From
is
January
like popping
to-
up so quickly.
Yep.
I'm curious whether it's changing faster than the lab can represent in Lima.
Yep. This is from January to August. Those are all the samples tested and from January to August. This is the result of this period. Well, and in the next diapositive, we're going to see that you can see in Lima, it's concentrating a lot of population. So we are going to see more cases in the city, but there are 12 cities that concentrated 80% of the cases. And one of the cities, Arequipa, is the city where I live. So you can see in red, it's in the square, we're also with high cases. So we're preparing for the third wave, and we're going to see in the next presentations how we're expecting it's going to be in September. This is the process of vaccination. We're receiving the vaccines since February this year. We started with the health workers. We're receiving the Sinopharm vaccine, but now this is the publication in August 25. We only have 7 million, around 7 million people who are really protected. So we're continue, and now in almost all of the city, we're vaccinating people from around 35 years old to older. And according to the vaccines who arrive, we are going to continue with the younger people. But now we're in 35 years old.
And now you have more than just Sinopharm, right?
Yeah. There are 3 vaccines. We started with Sinopharm. All the health workers, myself, I will receive it, Sinopharm vaccine. It was the first one who arrived. But then arrived with Pfizer. Most of the people received Pfizer. And in the jungle and in the altitude, they received AstraZeneca. There are the 3 vaccines that we receive until now. And in the next Holly, we can see the mortality in medicine doctors. This is very sad because many of friends, doctors, teachers died during the pandemic, and it was higher in July last year. Until now, it's 493 medical doctors who died. In February to June this year, 265 doctors died, but only 60 were confirmed with COVID. And from these 60, 39 had no vaccines, okay? And 7 didn't have any doses of vaccines. This was a report because many doctors asked for a third doses of vaccines. So the Ministry of Health showed this data to show that the mortality also was because some doctors didn't want to receive the vaccines, even though the first doses. But according to the studies that were shown by the Ministry of Health, also after the vaccination in February, the curve decreased so much in the mortality of doctors. In the other medical workers, it was similar, but it was almost 50% of the people of the number that we found in medicine doctors. I mean, if we had almost 500 medicine doctors who died because of COVID, for example, in the nursery, they died about 200 nurses, less than 50% of the doctors. But that is the reality. Until now, in August 22, around almost 200,000 people died in the country. About children under 18 years old, 100,000 were affected, but 349 died, and in the second wave. But we have to notice that, for example, in Arequipa, we only have 6 children who died.
So winning doesn't scratch me.
Sorry, there is a question? Okay. In Arequipa, there were 6 children who died. Most of them, five of them, had another disease like leukemia, some other comorbidities. So they are not totally because of COVID. They had other diseases who provoke the deaths of these children. Actually, in Peru, the children don't go to school yet. I mean, the schools are not all totally open, only in some areas in the altitude. But they have so few students that it was not a problem. But now there is a lot of discussion about to open or not. But we don't have now any date probable when they are going to be open yet. The vaccines for children, they were postponed during the pandemic, but after some months, we open again and we're trying to advance. It's not the same number, are not the same goals like the time before pandemic, but we are not so far. We are working on that, and I think it's gonna be regular next year. And still in the public areas, we have this 2-mask indication, we have to use it. This is a picture of the Institute of Children in Lima, an intensive care unit of children. And there is an interesting case that I wanted to show you about Daniela, because I remember the name because it's the name of my niece too. And it was in February, this 9 years old girl. She got a COVID, or her family too, and she was hospitalized, and after some days, she entered to the intensive care unit, and she was intubated. More than 70–100% of the lungs were affected. But after many days in intensive care, she lived, and she was diagnosed by with Guillain-Barré. So it was slow recovering now, but she's alive, and her family was doing these interviews in television about how they were working, how they were fighting with the disease, and they were happy that she's alive, but she's still recovering. And now we have some pictures. I am working in the first level. I'm in a medical center, 1-4, so we work 24 hours a day, and we see the liver. And this is a special patient that I took a picture, and she's Paola. And I like it to take this picture and share it with you because his baby, Luis, he after he was born, he was suctioning so well that I wanted to show you that. And this is the way how we are working now. You can see all the personnel are using masks, are using all the protection equipment, and also the patients. And we now, as it was a long time of a pandemic time and people, we were in quarantine for many periods. Now in these months, we have a lot of pregnant women. We now are increasing the deliveries, so we are preparing also for that. You know, during this time, you can see better now that the Luis is lactating very well. Okay, the third wave is coming, and we are estimating that in September it's gonna be. But let's hope the Minister of Health said that it could be less harmful because of the vaccines. We waited it could be that way. So we have 2 scenarios now that the probable scenario, it's going to be around 67,000 people who can die. And in the worst scenario, we're going to have 150,000 people in the country. So we have to prepare, and we still say to people that don't that they continue taking care of their biosecurity. We're trying to that people realize that even if they get the vaccines, they can be infected again. So we're worried about that, but we continue working. and we continue fighting everyone since their places. And it's a difficult time for the health workers because we're not enough. We're not enough, and many people has gone. And the new students, even I'm not sure how it's in the States, but here all the intern students were retired from the hospital since last year. They entered again in October last year, but only 50% of the time, of the usual time. And now they are again going, but only to hospitals, not COVID hospitals. I mean, the COVID hospitals or the COVID areas, they cannot enter there. So they only are in the COVID. So they have less time in the medical centers. We're working with the police and with the army. It was also in the beginning of the pandemic because they helped us to control the people, even in the areas, no COVID, in the COVID areas, to organize the people. During the quarantine, they also helped a lot, and during the vaccine process too, because they have to protect the vaccines, because we were afraid that they can be, yeah, they but people could want to take the vaccines. No? So the police and the army were helping us in all these consultations or all these problem, all these campaigns of vaccination. Okay? And there's some pictures of how we work in the no COVID areas, even in the parks, even in the open areas. We put these tents and we can see the patients. It's safe for the people, it's safe also for the health workers, and sometimes the medical centers are too full. So it was a good way to work also.
Can I ask a quick question, Doctora?
Yeah.
Just curious how you mentioned many of the health providers were affected and many of them died from the infection, and that there was already a lack of adequate resources even before the pandemic, and this has just stressed it further. Have you needed to use any creative solutions in terms of task shifting or up training, or how have you kind of filled that very rapid hole in skilled providers to be frontline medical providers, given that medical training takes years and years?
Yeah, if I understand you well, if we found some way to have the health workers, health providers, do you mean that?
Right. Mm-hmm.
Yeah. Okay. Well, now we have to enter to the virtual classes, to the virtual meetings, and even to arrive to not only the health workers, but also the population. We use so much now the WhatsApp and the Zoom, and with the health providers, even the students were trained by virtual. And now they started coming to the medical centers, but after receive the vaccines. There's the requirement to enter again, and they enter first to the no COVID areas. In the COVID areas, we don't they cannot enter yet. But after we finish the career, every health worker, every professional, we have to go to work to rural places. It's a requirement to have an employment with the government. So we have to go very far for 1 year, and then we can work for the government in any hospitals. But during the pandemic, as we need many doctors, as we need many nurses, this requirement was not necessary. I mean, I worked with doctors who months before were my students. They graduated and started to work in the hospitals. So that's why they found that they be hired very fast. Even doctors that usually take years or many months to convalidate the certificates of doctors from other countries, they accelerate this process so they can enter to work. And to be honest, also the government almost doubled the salaries of the doctors who entered to COVID area. I mean, who were hired to work in the COVID area because of the risk. It was a good, good
no,
option.
I'm just running out.
Yeah, like a huge incentive to staff that area.
Yeah.
And I think there was so much, like, personnel is one issue, but then equipment and infrastructure also were a huge issue, that, you know, from just personal experience of family members down there, that even recently family members who have had COVID and needed oxygen ended up sourcing oxygen tanks and being on nasal cannula at their home, which I've heard enough that it seems like it's a semi-common thing that people are getting oxygen for their home delivery, and instead of going to the hospitals. Do you think that's true, Angela?
Yeah, that's
not that I
true.
endorse it, but it is happening.
Yeah, it's happening, and I can tell you that even the doctors, yeah, yes, we work in with relation from one hospital to another, from one city to another, and we have these groups in WhatsApp, and we communicate how it's going, the situation in every place, so we have the first information. But even for us, it was so difficult. I was checking during the months of June, July, the worst time, doctors in the jungle that were checking patients, the intensive care doctors that were asking to be translated to Lima because they don't have enough oxygen. The doctors, you can imagine if the doctors, they don't have enough oxygen to treat themselves, how are the patients? So they were saved because of the medical college. They have to rent these planes, small planes, to transport it. That is very expensive here, to transport these doctors from jungle to Lima, from the north to Lima, from the south to Lima, for an intensive care unit space. Many of them were saved, but many of them couldn't do it. So it was very, very sad. I could see it from the medical community that every week some doctor was dying. And we're seeing they were our teachers, they were our colleagues, our friends. It was too much. But even this happened to medical doctors. You can imagine how it was for the population. I have friends, medical doctors, with they lost their parents, and it was like 3 of them that are close. They lost their parents in 1 week. It was too much. I mean, it was too hard to see how people was going, and many of them were going because we didn't have enough oxygen in that moment. We didn't have enough, and it was too much expensive, like 1,000% more than usual to get these balloons, and no everybody could afford it, and it was very difficult to get it. So I can tell you with total honesty that many people died because of our system were not prepared. We didn't have enough oxygen. We didn't have enough intensive care unit, and we didn't have enough doctors either. That was the problem. And about the mortality that was in the graphic that Holly showed, it is true because the official numbers were some, but after 1 year, when they compare the expected deaths in the country during the same period before pandemic, we could see the difference. And so they have to show the difference between these two periods, and we can see the real statistics that of people died. If I explain well, I mean the official numbers at the beginning were not true. When we compare with the others years, we could see the real numbers and we could see how high was the mortality in our country. So
yeah, the numbers that I showed are a reflection of the correction that was made once the statistical departments within the Ministry of Health in Peru saw the excess death and then adjusted the COVID, because testing was a huge issue for an incredibly long time. And only I feel like semi-recently has PCR become widely available. For gosh, I don't even know, when would you say the switchover happened, that it went from having a rapid test be the diagnostic test to using PCR. And so I think that appropriately they made that adjustment to reflect it, because so many deaths that were related to COVID couldn't be identified as that because of testing.
Yeah, that's true. The PCR was only tested in Lima. At the beginning, we didn't test the PCR in all the cities. So we have to take the sample here and send by plane to Lima. And there was the result after 1 week. And as you can imagine, we couldn't do it to every patient in the cities. So after that, we received the serological test that also were not the best. I mean, actually, we are doing the antigen test that it's better, but even we don't have enough. So many diagnoses are made by clinical, are not by test. So we're using data to follow the patient. The problem is that the problem of the mortality at the beginning is that they only take COVID as diagnosed with a test result. And if we didn't have enough tests, it was not possible that many diagnoses were confirmed. So that was the problem at the beginning with the numbers.
I mean, it's amazing what you all were able to accomplish with such limited resources, though, given that, Angela. And I also just think, like, looking at all these pictures of everyone outside, Arequipa has like the best weather in the entire world, basically 10 months of the year, and allowing everything to get so much to get moved outside is like pretty amazing. And we don't have pictures here, but even like when things were really bad, there were beds outside where people were overflowed to be waiting admission with their oxygen, like waiting outside in beds and stuff like that, which is pretty incredible.
Yeah, it was too much even for the health workers, because we have many people, many patients inside the hospitals that couldn't have a contact with the family. So I was doing sometimes monitoring by telephone, and I have to ask the hospitals how it's going, this or this patient. I have to call the family and explain, but they couldn't say goodbye directly. It was not possible because there was not enough personnel in the hospitals to try to communicate. We needed more hands on. It was not enough, as I think it was the same scenario in many places, no? In many countries.
And I think that when things were so overcrowded, like especially last July, August, September, there was an awareness within the general population of that overcrowding, and people would wait at home and not go to the hospital because there was this fear of getting separated. You would be by yourself, and especially given how much it's the elderly population. In Peru, nobody lets any older generation person, they don't go to the doctor by themselves mostly, like somebody will kind of take them. And so I think it was really hard for families to consider dropping off people to be then by themselves. And I know from my own experience, I mean, like my mother-in-law, my entire family down there had COVID, pretty much all at the same time last August. And when my mother-in-law had it, my sister-in-laws are nurses, so they have pulse ox monitors. And there was one night where we were watching her pulse ox, and it was like in the 80s, and we didn't have an oxygen supply, and we waited it out, and it got better the next day. Thankfully, she didn't have to go to the hospital. But that night was the worst, because we were like, are we doing the right thing? Like, we don't want to drop her off. It's way overcrowded. I don't even know if there's oxygen at the hospital right now anyway, but like, what if it gets worse and we've left her at home without trying, you know? It's just like, it's impossible scenarios that I think so many people were running through. And I mean, I'm sure you're in the same situation, Angela, but so many people within our community died in Peru. And then here in the United States, so many people have died, but way fewer peers and members of the community in comparison. And I think that kind of like, I saw an article recently just about the number of children who have lost parents in Peru because that age for mortality is much more expanded because of the limited resources that were available and ICU beds and stuff like that. And so huge percentages of kids have lost a parent, or if not a parent, a grandparent because of it. And I mean, my kids, the person who drove them to school every day died, and the person who delivered the milk died. And it's just like,
it's what is
get your
happening.
head around, you know?
Yeah, you're right, because in the last months, I mean, this year, since I think March to August to July, the higher number of mortality of deaths are in houses. I mean, it's not in hospitals. So we formed these equipments. We said in Spanish, equipo de recojo de cadáveres. I mean, it's a team that goes to the houses to pick up the bodies. There were teams, and they have to go to the places to disinfect and take the bodies. And it has increased a lot in the last months. I mean, not in the hospital, but in the houses. And it's because of that, because once they enter the hospitals, they don't have the communication with the family, and the patients, they don't want to go to the hospitals. In the general hospital, that is a COVID hospitals, until last month, there were 5 suicides during the pandemic of patients with COVID that they jumped from the 4th or 5th floor, but it was until now 5 of them, and they were young people. I think the last one, it was like 42 years old, man who jumped. Yeah, it's they tried to do the psychological equipment, but it was not enough. Where
Oh my gosh.
there was, I remember because it was in the media, and I asked friends there. It was the 5th during all this pandemic.
Yeah.
And there was a question that it was asking how it's the people, how it's living, how it's the population in every house, how many people live. For you to have an idea, in April, we made like we went house by house to see for patients. In the medical center, we have this strategy to see patients with comorbidity. So I went to 2 blocks. I mean, two blocks of houses, and in these 2 blocks, it took me like 2 days, and I found around 100 people only in 2 blocks. So you can imagine, more or less, it's are many people living in one house. And because here it's very common that in the houses of the parents, they divided, and for the son or daughters, and there is still small families in the same house, maybe in small departments, but they're still in the same area. So
We
in
build
two,
on a little room for then
Yeah.
the younger generation family to live.
yeah,
Huge,
and they
huge
live
overcrowding.
with the grandpa or grandmother there, so they are together. So it
Yeah.
doesn't help also for the COVID. For COVID.
No.
And
I want to make sure we leave time for questions.
Yeah, we have one in the chat. I can read it.
Oh,
for
yeah.
you. Or Meron,
Thanks.
if you want to come off mute, if you feel comfortable asking it.
I just wanted to thank you for this presentation and all the amazing work that you're doing. A question I had was, I feel like they're all over the world, there's just been a huge impact on like trauma of like medical providers. So if there was any initiatives revolved around like providing mental health services for medical providers in Peru.
Angela, do you know?
So,
I haven't
I
heard
did-
myself. Is there resources for healthcare doctors, nurses to get mental health services?
Before the pandemic, I mean, it was like 4 years before we started to open this mental health mental centers. Okay, so for example, in Arequipa, we have like 150 medical centers, and we have these mental health centers. They are around 15 in all the city that are open. Okay. But for they helped a lot as for the also for the health workers, the psychologists during the pandemic, they went home and they were working from home because they were not health workers in the first line. I mean, all the people and nutritionologists, psychologists, I mean, other careers that are not really in the emergency, they were sent home for the biosecurity, and they could work in this remote work by phone or by video conference. I think after the vaccination, they returned to the medical centers. They are helping us with that. But to be honest, during the pandemic, the government spent a lot of money that they usually didn't spend, paying the people who were hired to enter to work. And as we know, the government we don't have so much money. So we think that in the next years, it's going to decrease all the budgets. Last year, in the residence, in the residence process, because I am part of this committee. We usually, for example, have in Arequipa 200 places for residents, because there is a contest every year. They do a test to enter to the residence program. But every year it used to be like 200 places. Last year it was like 80 places, and many hospitals, they closed all the places for the residences, because we were asking for that because we need more intensive care doctors, we need more anesthesiologists, emergency doctors. The problem was that the budget was not enough for the 3 years of training for the salaries. And as the government spent a lot of money in hire personnel and give bonus for the population, for the people in quarantine, there are coming time with less budget. So I saw it in the residence program. They decreased a lot, more than 50%. And we were fighting to they continue, but it was at least they increased a little, but not much. This year, keep the same in the same line. So I think in the next years, we're going to decrease a little the budget or the sponsor for the projects or in all the areas, not only in health.
Yeah. And we didn't even get into the sort of massive social upheaval that all of this has caused with politics and a new president who's very far to the left, and the way in which changes in these policies are going to affect the public health system, which I think is a question mark at this point, as far as I can tell.
Yeah, I mean, I think you're right, Holly, right? Like the ripples of this pandemic will go so much further into the future and are so much larger than the immediate impact on health. I mean, that effect on training right there in itself, that's for generations to come.
Yeah.
You might feel that. I want to.
And once you cut things, it takes so much dedication, effort to really bring them back to the level that they were before. I mean, it could take a really long time. It goes totally in the wrong direction, so it's hard.
Let everyone know that I put a link in the chat to please fill out the session evaluation. It's very brief. It only takes a minute or two. And then I wanted to thank both of you for your time, and thank you for this very honest and realistic view of the effects of COVID in this particular situation. So thank you so much for your time. And if you want to put your emails in the chat, if people have follow-up questions, they can contact you separately.
Thank you.
Yeah,
It was an honor.
Thank you so much.
Yeah, anybody, please reach out to me anytime, and I'm happy to stay on if there's other questions, but thank you guys so much for joining us. And Angela, thank you so much for coming and joining us and telling us about everything, and I appreciate it.
Thank you very much, Holly, and thank you for organizing these interesting lectures. It was an honor for me to share with you after a long time, Holly. After a long time. Thank you.
Thank you all.
All right, thank you very much.
Bye.
All right, I think I'm gonna hop off. It looks like everybody is.
All right,
It's
thanks,
gone.
Holly.
Okay,
Have a
thank
good one.
you.
Bye.
All right, bye-bye.